Well, what I'm going to do basically, I will speak on the topic from the perspective of the clinicians and gynecologists in terms of the role of omics, which includes proteomic, genomic, and metabolomic, to see the link between polycystic ovarian syndrome and endometrial cancer. I must say, as a clinicians and gynecologists, we are facing a huge dilemma in managing endometrial cancer as well as polycystic ovarian syndrome. What more, when the current evidence so far is very limited to suggest what is the best treatment options or preventive strategy in polycystic ovarian syndrome. But the first questions that we must ask, is there any strong evidence, or is it true that polycystic ovarian syndrome put women at high risk of getting this endometrial cancer? It's very difficult to say. All right? So, for today's presentations, I will highlight a few important issues. The first one, I will illustrate the burden of endometrial cancer worldwide in general. Secondly, we'll go through the pathophysiology of the polycystic ovarian syndrome and see what are the linkage between PCOS and endometrial cancer. And lastly, I will touch a bit on the metabolomic, which is the integral part of the Congress today. Right, so endometrial cancer is one of the commonest gynecological cancer in North America and Europe. And we can see the number is almost about 4,000 in 100,000 women dying in Europe in the year of 2010. And if you can see, the number is increasing, whereby you can see almost about 50% of the cancer cases being diagnosed from the year of 1990s to the year of 2010. And worldwide, endometrial cancer is the 5th common cancer, with the number of roughly about 288,000 in 2008. And we are projecting that the number will be further increased by about 50 to 100% in 20 years' time. This is very alarming facts that we have to face today to make sure in the future we're able to do something about it. Okay, this is basically the statistic from UK to see the cases of the endometrial cancer in the year of 2010. And when you can see from here, the number of endometrial cancer which being diagnosed is creeping from time to time until the data that we have so far in 2010. And worldwide, as what you can see, majority of them coming from America and Europe. Well, it is very important, if we were to talk about the endometrial cancer, to note that there are two different types of cancer, namely type 1 and type 2 endometrial cancer. But in terms of polycystic ovarian syndrome, we are more inclined to talk about the type 1 endometrial cancer, reason being because the physiology or the pathophysiology between the pathophysiology in endometrial cancer type 1 is because of the hormonal imbalance, namely because of the higher estrogen as compared to progesterone, which has the protective effects against cancer. But then it is good to note that the type 1 endometrial cancer is less invasive, therefore they have a better prognosis compared to type 2 endometrial cancer. And again, if you look at the statistic, majority, about 3/4, 70% of the patients diagnosed to have cancer is between 40 to 70 years of age, which is most of them having type 1 endometrial cancer. Why we're so engrossed about this problem it is not only just to make sure our women live happily with their intact uterus, but we as taxpayers have a concern about the budget of managing the endometrial cancer. What we have so far is found that it is estimated about roughly about $14,000 is being spent to manage a single case of endometrial cancer when we are treating with a standard treatment options. And about 13 million of UK population will be obese by the year of 2030. Can you imagine how much more that we got to spend on the treatment of this problem? And obesity itself is one of the risk factors of having endometrial cancer, and it is a subset in the complex disease of polycystic ovarian syndrome. Just a glimpse on the polycystic ovarian syndrome. It is a complex metabolic disorders among women in their reproductive age. In general, it's roughly about 10 to 20% of women having this problem. It is very difficult to diagnose, but at present moment, we are using a Rotterdam criteria, which is categorized by the chronic end ovulations or oligomenorrhea with clinical and or biochemical evidence of hyperandrogenism and also polycystic ovaries appearance on the scan. 2 out of these 3 will give a high suggestions or will suggestive highly on the polycystic ovarian syndrome. What are the clinical implications? Why we're so bothered about this? The problem is it is not only have a problem in conceive or trying to get pregnant, fertility problem, but to the later stage, they are at high risk of getting endometrial hyperplasia, which is a pre-invasive conditions, and also endometrial cancer. And what evidence that we have so far is showing that from the systematic review is about 3 times high risk of getting endometrial cancer among polycystic ovarian syndrome compared to general populations. All right? So what is the pathophysiology? Why? Why are we trying to link between PCOS and endometrial cancer? It's found that the core problem in polycystic ovarian syndrome is because of hyperinsulinemia and insulin resistance. And because of that, it causes dysregulations of FSH, LH, which is being produced by the pituitary of the brain. And because of that, it causes imbalance of estrogen and progesterone hormone. We know that estrogen overexpressions in the endometrial cavity, putting women at high risk of getting womb cancer. Otherwise, progesterone is good as a protective mechanism. And later, with high or increment of this progesterone, it will later convert by aromatizations to androgen, which is also another culprit of the pathogenesis of the cancer of the endometrium. So we know that hyperinsulinism, insulin resistance is a major role in the pathogenesis of PCOS. We know that the presence of IGF-1, IGF-binding proteins is very strongly correlated to the endometrial cancer, and in fact, the intensity or the numbers of IGF is correlated to the higher degree of endometrial cancer. So it's something to do with the insulin metabolism. It's not only that, there's increasing evidence on the other genes that are responsible to the insulin signaling pathways, such as P1-3K, AKT, RAS, and MAPK. So there are studies that look at the presence of insulin as well as the testosterone in the progressions or in the expressions of multiple genes which involve AKT, IRS, mTOR, as well as S6K. So as what we can see from here, the effect, even without the testosterone, the cells is being overexpressed in cancer. So this is the results from IRS phosphorylation and mTOR together with S6K phosphorylation. There are other studies on the cultured endometrial cell shows that the expressions of the migration of the cancer cell is higher when they are being treated with the luteinizing hormone as well as HCG. And there is also a studies which look at the endometriums of normal women and women with PCOS, and they found that the expressions of receptors, estrogen receptors as well as the androgen receptors, is higher in the PCOS woman compared to the normal woman. But as expected, the progesterone receptors is slightly is lower in the PCOS compared to normal. There is other studies, quite interesting, whereby looking at the women with various conditions, which include normal endometrium, PCOS lady without having hyperplasia or pre-malignant conditions of the endometrial cancer. This is PCOS with endometrial hyperplasia, and third patient is hyperplasia without PCOS. And this is the results that they found, whereby in a PCOS as well as PCOS with hyperplasia, the expressions of PKT and RAS is higher. The same thing with the expressions of P27, cyclin A, and CDK2. So we know that it's not only the insulin pathways are responsible to the pathogenesis of the problem. It also involves other genes, which is CDK2 and P27, CYR61, and other steroids, sulfatase mRNA, which is involved in the insulin resistance mechanism. So where are we now? So we basically have some rough ideas that PCOS has high risk, or giving them at high risk of getting endometrial cancer. In that case, we would like to integrate between genomic knowledge, proteomic, and metabolomic to make sure the results are going to be stronger, so that we can suggest or we can recommend a better treatment for high-risk patients of developing this cancer. So our research group started with a pilot research looking at the metabolomic in the polycystic ovarian patients. So we have two arms, basically PCOS and normal patients. So what we could find here, basically, there are subtle changes in terms of the amino acid in the plasma of patients with polycystic ovarian syndrome. And when we do a cluster analysis, the component analysis, it looks like it's quite distinct difference between the PCOS group as well as the control group. But again, this is just a pilot research whereby need further validations in the future. So what's the directions that we are on now? So now we are at the final stage of analyzing samples for the gene expressions, which include the insulin pathways as well as the lipid pathways. And at the same time, we're also doing a metabolomic analysis from 3 different arms. We have a normal patients, patient with polycystic ovarian syndrome, and thirdly, patient with type 1 endometrial cancer. And we hope the results, which I'm not going to disclose today, will be able to validate the previous pilot study, and at the same time, we're able to determine the specific biomarkers profile for the endometrial cancer. And next step, we will be able to see the link between polycystic ovarian syndrome and endometrial cancer. And by knowing this, I'm sure we would be able to generate a good bioinformatic analysis to see the correlation of the link between PCOS endometrial cancer in terms of proteomic, genomic, and metabolomic. Therefore, it should be able to help us to manage our patient better. With that, I thank you.